Hello everyone. In today's session, we are going to discuss about the acute respiratory infection. It is a continuation to the topic. In the part 1, we have discussed about the definition, the classification of the respiratory infections into upper respiratory tract infections and the lower respiratory tract infections. The problem statement, epidemiological determinants, risk factors, mode of transmission, clinical assessment, clinical features, the physical examination. Continuing with, in the part 2, we are going to discuss about the classification of an illness, the management, prognosis, complications, immunization, and general advice. To begin with, the classification of acute respiratory illnesses. In integrated management of neonatal and childhood illnesses, the children are grouped according to their age group. So, what did they do? They divided the children according to the age group, they grouped them. The children in the group 1 are aged between 2 months to 5 years, and the group 2 comprises of a young infant 0 to 2 months. So you can see here the classification of disease based upon the age group. The young infant 0 to 2 months, and the child 2 months to 5 years. The two groups you can see, young infant 0 to 2 months and the child from 2 months to 5 years. A child aged 2 months up to 5 years, they are classifying the illnesses. It means we are making the decision about the type and the severity of the disease. Okay, we are classifying them to understand the type of the disease, what the child is going through, and also based upon the severity of the disease. The sick child can be put into one of the 4 classifications. The first classification is a very severe disease. You can see the child can be put into one of these classifications. The first classification is a very severe disease. And the classification 2 is the severe pneumonia. 2, severe pneumonia. 3, the young infant, the classification 3 will be empty. Whereas in the child up to 2 months to 5 years, we have pneumonia which is not severe. And the fourth classification, under the fourth classification, the young infant will be categorized into no pneumonia, cough or cold. Even the child 2 months to 5 years, the fourth category will be no pneumonia, just cough and cold. Each of these categories under each subgroup will be discussed in detail, and once you discuss all of that in detail and come back to the slide, you will have a better clarity. You can make this column on your own. We will come back and revise to this. For now, let us begin with the classification. Let me just revise now. What did we study? The 2 age groups. What were the 2 age groups which were classified? The group 1 was the young infant aged 0 to 2 months, and the child was 2 months up to 5 years. Okay, is it clear? The 4 groups we'll discuss now. The age groups are clear. Now let us start with the child aged 2 months up to 5 years. Classifying the illness means we are making a decision about the type of the disease, the severity of the disease. The sick child should be put into one of the 4 classifications. What were the 4 classifications we saw? Very severe disease, severe pneumonia which is not severe. See, very severe disease. One is a very severe disease. Then comes pneumonia, severe pneumonia, and the other one is not severe. The second one is not severe. The 4th classification will be no pneumonia. There is no pneumonia, only cough or cold. Okay, to begin with, very severe disease. The danger signs and possible causes of the very severe disease are: the child will not be able to drink. A child who is not able to drink could have a very severe pneumonia, or he could have bronchiolitis, septicemia, there could be throat abscess, meningitis, or there can also be cerebral malaria. Is it clear? A child who is not able to drink could be having all of these things. What are those? Bronchitis, so bronchiolitis, severe pneumonia, septicemia, throat abscess, meningitis, or cerebral malaria. The second danger sign will be he will undergo convulsions or could be abnormally sleepy or very difficult to wake. A child with these signs may have very severe pneumonia. It can result in hypoxia, sepsis, cerebral malaria, or meningitis. Meningitis can develop as a complication of pneumonia, or the meningitis can occur on its own as well. Is it clear? The child who is not able to drink will have either severe pneumonia or meningitis, cerebral pneumonia, septicemia, throat abscess, bronchiolitis. Again, the child with the convulsions who is abnormally sleepy, he is difficult to wake up. Again, under the subheading, what are you supposed to write? He might be undergoing with sepsis, cerebral malaria, meningitis, hypoxia, severe pneumonia, etc. The next signs are stridor in a calm child. If a child has stridor when he is calm, the child may be in danger of a life-threatening obstruction of the airway. If the child has stridor, stridor is an abnormal sound which is produced on inspiration. So when the child is calm and yet you can hear the stridor, it means that the child is in a life-threatening obstruction of a airway. He is in danger because of the swelling of the larynx, trachea, or epiglottis. Clear? And then the severe malnutrition. The malnutrition, when present, it is a high risk. The children, a severely malnourished child, is at a high risk of developing and dying from the pneumonia. So under the high risk factors, we have already discussed that severe malnutrition is one of the major risk factor for severe pneumonia in the children, and it is one of the high risk factor for fatality in infants and the young infants and the children aged 2 months to 5 years. So the severe malnourished child is at a higher risk for developing and dying from the pneumonia. In addition, the child may not show the typical signs of the illness. Since the child is all malnourished, the indrawing of the stomach cannot be very well distinguished from the pneumonia. So it is difficult to find out the typical signs of the illness in the malnourished child. Moving further to severe pneumonia, the chest indrawing with or without the fast breathing. Is it clear? We discussed what did we discuss in the first thing? The first subheading, that is very severe disease. We discussed the very severe disease, the classification of illness under which very severe disease was done. Now we are going to discuss about the second thing, that is severe pneumonia. The most important signs which we need to consider when deciding if the child has severe pneumonia or not is the child's respiratory rate and whether or not there is chest indrawing. Okay, a child with the chest indrawing may not have a fast breathing. If the child becomes exhausted and if effort needed to expand the lung is too great, then the breathing will slow down. In such cases, the chest indrawing may only be a sign in cases of the child with severe pneumonia. Is it clear? The chest indrawing with or without the fast breathing. You have to focus on the chest indrawing. Sometimes the chest indrawing may not be there. Even the child without the fast breathing, there will be chest indrawing, or there cannot be fast breathing, yet the chest indrawing will be present. Why there is no fast breathing and yet there is chest indrawing? It is because the child has become exhausted now and he has no effort left. So what happens? There is chest indrawing, but the fast breathing is not present. There is a slow breathing in such children. So in such cases, you see that chest indrawing only will be the sign in cases of the severe pneumonia. A child with the chest indrawing, there will be at a higher risk of death from pneumonia than a child who is having just fast breathing. The next sign will be a nasal flaring. A child who is classified as having severe pneumonia also has other signs. What are the other signs we see in the children? That is nasal flaring. When the nose widens as the child breathes in, the nose will get widened. That is nasal flaring. Then we have grunting. Grunting are the short sounds which are made with the voice when the child has some difficulty in the breathing. The child grunts those short sounds which the child makes when there is a difficulty in breathing is grunting. And then comes cyanosis. Cyanosis is nothing but the dark purplish bluish discoloration of the skin which is caused because of the hypoxia. There is a decreased level of oxygenated blood supply, so there is hypoxia which is resulting in the cyanosis, which is the bluish and purplish discoloration of the skin. Then comes wheezing. Some children with the chest indrawing also can present with wheezing. Okay. Children who have chest indrawing and a first episode of wheezing often will have severe pneumonia. You see, a child has come who is having the chest indrawing, and also there is a first episode of the wheezing. He will have a very severe pneumonia. However, children with the chest indrawing and having a very recurrent wheezing must often do not have the severe pneumonia. So there is more with the other diseases who are having recurrent wheezing and chest indrawing, they do not come under the severe pneumonia. However, the children with the chest indrawing and recurrent wheezing most do not have the severe pneumonia. The chest indrawing in these children can be caused by the asthmatic condition. Clear? Therefore, they must be assessed before deciding the line of the treatment. We need to assess if it is severe pneumonia or it is the asthmatic condition. How can we decide it? Based upon the episodes of the wheezing. If the child has indrawing and comes up with the first episode of wheezing, it is severe pneumonia. If the child has chest indrawing plus recurrent wheezing is present in the child, then it is the asthmatic condition. Based upon this, we need to decide the line of treatment in them. Is it clear? The severe pneumonia, can we just quickly revise all the points? What did we see? The first point what we saw was the chest indrawing. The most important sign whether the child is having pneumonia or not is based upon the respiratory rate and chest indrawing. What did we see? If the child has chest indrawing, see, let me just zoom in. Okay, what are the signs we saw? Yeah, wait. So we saw in cases of severe pneumonia. We will revise all the points what we discussed. Severe pneumonia. In severe pneumonia, the first point was chest indrawing. The chest indrawing could be along with the fast breathing, or there cannot be fast breathing. Why no fast breathing? Because the child is exhausted. So the chest indrawing is the most important thing which you have to see, not the breathing rate. The second point what we saw was the nasal flaring. The nasal flaring, when the child breathes in, the nose will get widened. And then we will see the short sounds which are made. The grunting, nasal flaring. Third comes grunting, the short sounds which are made by the child. And then we have fourth point is the cyanosis. And then we will see the wheezing. Lastly, we saw the wheezing. The first episode of wheezing, then it is severe pneumonia. If the child has recurrent episodes of wheezing, then it is an asthmatic condition. Clear? Yes. Yeah. Next we are going to discuss about all of these points: chest indrawing, nasal flaring, grunting, cyanosis, wheezing. Next we will move further to pneumonia, which is not severe. A child who has fast breathing and no chest indrawing is classified as having pneumonia, which is not severe. Clear? Fast breathing is present, fast breathing is there, but no chest indrawing, then he is having pneumonia which is not severe. Okay, no chest indrawing is the pneumonia which is not severe. Most children are classified in this category if they are brought early for treatment. What are the signs we see? Obviously, no chest indrawing and fast breathing. the breathing rate is recorded. The most of the children are classified under this category if they are brought early for the treatment. Also, the management of the child with the pneumonia not so severe, we will discuss in the next slides, the under the management. And we see that the respiratory rate will be 50 per minute or more if the child is aged 2 months up to 12 months. Up to 1 year, the breathing rate will be fast breathing. It is characterized as fast breathing if the breathing rate is 50 per minute. 40 per minute or more if the child is aged 12 months up to 5 years. Is it clear? The fast breathing will be present without chest indrawing. That is all you have to remember under pneumonia not severe. If you want to specify the breathing rate, it is 50 if the child is aged up to 1 year. It is 40 if the child is aged up to 1 to 5 years. No pneumonia, cough or cold. Now we have come to the fourth classification where there is no pneumonia, cough or cold. Most children with a cough or difficult breathing, they will not have any danger signs or danger signs of pneumonia, that is chest indrawing or fast breathing. These children will only present with a simple cough or cold. They are classified as having no pneumonia, simple cough or cold. Normally a child with cold, they will get better within 1 to 2 weeks. However, if the child presents with a chronic cough, the cough which is lasting for more than 30 days, more than a month, the child who is having a chronic cough may have TB or asthma, whooping cough or some other problem. Refer the child with a chronic cough for the further investigations. We need to refer the child. Is it clear? These children, now what will you remember in no pneumonia, cough or cold? These children will have the simple cough or cold. They are classified as no pneumonia, cough or cold. They do not need any antibiotics, and much of these cases will be the viral infections where antibiotics are not effective. They will get better just within 1 to 2 weeks. No need of any antibiotics for these children. Majority of these cases will get better, okay, within 1 to 2 weeks. So if the cough is lasting for more than 30 days, then there could be some underlying disease like asthma, whooping cough, TB. Then we have to refer the child who's having the chronic cough for the further investigations, and the management is classified in the upcoming slide. Next, we will move further to the management part. The management part of no pneumonia, cough or cold. What are the signs? There will be no chest indrawing, no fast breathing, and breathing rate will be less than 50 per minute if the child is aged 2 months up to 12 months, and less than 40 if the child is aged 12 months up to 5 years. This we have already discussed. What is fast breathing? Fast breathing is more than 50 per minute if the child is up to 1 year, that is 2 months to 12 months. More than 40 per minute from 1 year to 5 years. So no fast breathing, in the sense it will be less than 50, less than 40. Treatment. If coughing is more than 30 days, we need to refer for the further investigations and assessment. Assess and treat the ear. If there is acute otitis media, we need to treat it and other ear conditions. If there is problem or sore throat is present, assess and treat the other problems in the child. And then we need to advise the mother to give the home care, treat fever if it is present, and also we need to treat the wheezing if at all it is present. Is it clear? What is the treatment you give? Other infections, ear, sore throat, other problems, they have to be treated. Fever if present, wheezing if present have to be treated, and we need to advise the mother to give the home care. Okay. Now we will move further to classifying the illnesses of the young infant. Is it clear? The illness of the children aged 2 months to 5 years, we know the classification, and we discussed the treatment as well. The 4 classifications we studied under that, and now we are going to discuss the other 4 classification of young infant 0 to 2 months. The 4 classifications will be studied. Here the 4th classification was no pneumonia, cough or cold. It is a very severe illness, severe pneumonia, not severe pneumonia, and no pneumonia, cough or cold. No pneumonia, cough or cold. Now let us see the other 4 classifications of the children age 0 to 2 months. That is not children, that is a young infant. Okay, young infant 0 to 2 months. Is it clear? Yeah. Moving further to classifying the illnesses of the young infant who is less than 2 months of age, they are referred to as the children aged less than 2 months of age are referred to as a young infant. Young infants have special characteristics that has to be considered whenever we are classifying the illnesses. We need to consider the special characteristics of these young infants. Okay, because these young infants can become sick very quickly, they die very quickly from the bacterial infections, they are much more less likely to cough with pneumonia, and they frequently have non-specific signs. Okay, these children have non-specific signs and they die quickly, get sick quickly, so we need to know the special characteristics of these infants. We classify the illnesses of young infants. We do not have the third classification. When we saw this table, we saw the third classification, it was empty. The 3 classifications you have to remember in this, that is very severe disease, severe pneumonia, and no pneumonia, cough or cold. Okay, what we revised in the previous slide, I had to write 3 classifications under young infant and 4 classifications under this. You need to verify this. I'm sorry, there are 3 classifications. Okay, the third one here won't come. Fine. Classifying illnesses of young infant, they are very severe disease, severe pneumonia, and no pneumonia, cough or cold. Okay, let's begin with very severe disease. Some of the danger signs of the very severe disease are convulsions, abnormally sleepy or difficult to wake up. And young infant with these signs may have hypoxia. Hypoxia could be from pneumonia, from sepsis or meningitis. Malarial infection is unusual in children of this age, so anti-malarial treatment is not advised. We saw the cerebral malaria to be one of the cause of the very severe disease and one of the cause for the convulsions and the child being abnormally sleepy and difficult to wake in cases of the children aged 2 months to up to 5 years. Here the malaria will not be a cause because malaria is less likely to occur in the age group of 0 to 2 months. Hence, the anti-malarial treatment is not advised in this age group. Stridor when the infant is calm. The infections causing stridor like diphtheria, bacterial tracheitis, measles, epiglottitis are rare in the young infants. A young infant who has stridor when calm should be classified as having a very severe disease. So these diseases like diphtheria, epiglottitis, measles, bacterial tracheitis, these are less likely or rarely seen in the young infant. So whenever the young infant presents with a stridor, especially when the young infant is calm, we have to classify him or her under a very severe disease. Stopped feeding well. A young infant who stops feeding well, that is, takes less than half of the usual amount of the milk, may have to be classified under the serious infection and having a very severe disease. So the child may be undergoing a very serious infection and we have to classify the child under the very severe disease. Then comes wheezing. Wheezing is uncommon in young infants and it is often associated with hypoxia. We see wheezing is uncommon, so it is associated with hypoxia in the young infant. Then comes fever or low body temperature. The fever 38 degrees Celsius or more is again uncommon in young infants and more often means a serious bacterial infection. So we can think of meningitis. Here, the low body temperature, the fever or low body temperature, both of which is uncommon in young infants, it means a bacterial infection. In addition, fever may be only a sign of serious bacterial infection. In young infants, an infection may sometimes cause the body temperature to drop, that is hypothermia. Is it clear? What are the signs of a very severe disease? Convulsions, abnormally sleepy or difficult to wake up. they'll have hypoxia because of the pneumonia or sepsis or meningitis. What is contraindicated here? Anti-malarial treatment is not advised because malarial infection is unusual. Then stridor when calm. Okay, stridor when calm. Then if the child has a stridor when calm, he has to be classified under the very severe disease. Stopped feeding well, may have a serious infection, should be classified under the very severe disease. Wheezing is uncommon in young infants. It is associated with hypoxia. Fever or low body temperature again is uncommon in young infants. It means they have a bacterial infection, serious bacterial infection. Is it clear? The very severe disease. Are the points clear? Convulsions, abnormally sleepy and difficult to wake up, stridor when calm, stopped feeding well. What is uncommon in young infants? Wheezing is uncommon in young infants. The fever or hypothermia is uncommon in young infants, and then malaria is uncommon, so anti-malarial treatment is not indicated. Okay, fine. Moving further to severe pneumonia. The signs of the severe pneumonia are severe chest indrawing, the fast breathing, which is 60 beats, 60 respiratory cycles per minute or more. So in the infants less than 0 to 2 months, the respiratory rate will be 60 per minute or more to be considered as fast breathing. The respiratory cycles will be 60 respiratory cycles per minute or more to be considered as fast breathing, plus the chest indrawing is present. If the child has to be classified under no pneumonia, cough or cold, then the infant with the no pneumonia, cough or cold will not have the severe chest indrawing, and there will be absence of the fast breathing, that is less than 60 respiratory cycles per minute. Moving further to the treatment, advise the mother to give the home care. Keep the infant warm. Breastfeeding have to be given frequently. Clear the nose if it is interfering with the feeding. Return quickly if the breathing becomes difficult and breathing becomes fast or feeding becomes a problem. The young infants become sicker. Okay, if the young infant becomes sick, we need to come back quickly to the hospital and report to the doctors. What is the treatment? Breastfeeding frequently, keeping the child warm, and while breastfeeding, if the breathing is obstructed, clear the nose and return quickly if the breathing is difficult, if the child is turning sick, and if the breathing is increased, the respiratory rate is more than 60 per minute, and if the feeding is becoming a problem, if the child is not feeding well, return quickly and report. Classification and management of the illnesses in the young infant. What is the signs? What under which it is classified, and the treatment. If the child has stopped feeding well, has convulsions, is abnormally sleepy or difficult to wake. When the child has stridor, in a calm child we observe the stridor, wheezing or fever or low body temperature, then we are classifying as a very severe disease. The treatment given is refer urgently to the hospital, keep the young infant warm, and give first dose of the antibiotic. Is it clear? What are the signs we see under the very severe disease? What are the signs we discussed? Stops feeding well, convulsions, abnormally sleepy or difficult to wake, stridor in a calm child, wheezing, fever or low body temperature, hyperthermia or hypothermia. Then the child has a very severe disease, should be referred urgently to the hospital, keep the young infant warm, and give the first dose of antibiotic. Next classification, if the child has severe chest indrawing or the fast breathing which is 60 per minute or more, then the child is classified as having severe pneumonia, and the treatment is refer urgently to the hospital and keep the young infant warm. Give the first dose of antibiotic. If referral is not feasible, treat with the antibiotic and follow up closely. Okay, keep the child under the observation and follow up closely, give the medications at the right time, and take a proper care of the infant. If the referral is not available, then wherever the child is admitted, they have to follow the child quickly and promptly. Then we move further to the next signs: no severe in chest drawing and no fast breathing. The breathing is less than 60 per minute. Then the child is classified as no pneumonia, cough, or cold. The treatment given is: advise the mother to give the following home care. What is that? Keep the young infant warm, breastfeed frequently, clear nose if it is interfering with breathing, return quickly if the breathing becomes difficult, breathing becomes fast, and feeding becomes a problem, the young infant becomes sicker. Moving further to the prognosis. Is it clear so far? Now we are moving further to the prognosis. The prognosis of acute respiratory infections varies based upon the factors such as the specific infection, the individual health, and the promptness of the medical intervention. So, based upon the treatment, the promptness of the treatment given, based upon his immunity, the individual health, and the specific infection, the prognosis depends upon these three factors. It is based upon the infection, the type of the infection, the severity of the infection, the individual's health, and the promptness of the intervention. Most cases of the acute respiratory infections are self-limiting. Meaning, what is self-limiting? They resolve on their own with the proper care. Okay, with the proper sanitation, hygiene, isolation. So they are self-limiting. They resolve on their own with their proper care. However, the severe infections such as pneumonia can lead to complications and they require the medical attention. Is it clear? The pneumonia can occur in acute respiratory infection. As a complication of the acute respiratory infection, the pneumonia can occur, which requires the medical attention. Early diagnosis and treatment plays a very crucial role in improving the outcomes of the disease. So, the early diagnosis and giving the prompt treatment at the right time will help us in giving a better outcome. Moving further to the complications. The complications to acute respiratory infections are the respiratory arrest. In severe cases, acute respiratory infections will lead to respiratory failure, where the lungs will stop functioning effectively. This condition is a very life-threatening one and it requires the immediate medical care. Is it clear? The complication is the respiratory arrest, where there is a respiratory failure and the lungs will stop functioning and we need to give the immediate care to the child. Permanent damage. Prolonged or severe infections will cause a lasting damage to the lung tissues. So, whenever there is a prolonged infection, a chronic infection, or a very severe infection, it will cause a lasting damage to the tissues. Then, the third complication is the death. Although rare, but the acute respiratory infections can be fatal, especially in the vulnerable populations like children, older adults, or individuals who are having a weakened immune system. The acute respiratory infections can be fatal. Moving further to the prevention of acute respiratory infections. In the developing countries, the improved living conditions, better nutrition, and the reduction of the smoke pollution indoors, they will reduce the burden of the mortality and the morbidity which is associated with the acute respiratory infection. So, how can we prevent the acute respiratory infections? First thing, the indoor smoke pollution, the use of HP, the cylinders, the gas stoves, and replacing the old methods of the blowing and igniting the gas, and then that has to be stopped, and instead the closed gas cylinders should be used by reducing the indoor smoke pollution and providing a better nutrition and improved living conditions. So if the overcrowding is stopped and each individual have their own space, this will reduce the spread of the infection and fatality rate, the mortality and the morbidity rates will lower down. Other preventive measures include the better maternal and child health care. Immunization is an important measure which is taken to reduce the pneumonia, which will occur as a complication of the vaccine preventable diseases, especially measles. So, we see that the measles vaccine, pneumonia, which is a serious complication of measles and the most common cause of the death. Pneumonia is the most common cause of the death which is associated with measles worldwide. Thus, reducing the incidence of measles in young children through vaccination will help us to reduce the deaths from the pneumonia. Is it clear? Once we start using the vaccination against the measles, reduce the cases of measles in the young children, they will obviously help us to reduce the deaths from the pneumonia, thereby reducing the deaths because of the acute respiratory infections. It is obvious that community support is also essential to reduce the disease burden. The families with the young children must be helped to recognize the pneumonia. Health promotional activities are especially important, especially in the vulnerable areas. We need to do the health promotional activities. They will help us to spread awareness about the pneumonia, and once the awareness is spread, the families can detect the children having pneumonia, and the quick referral to the hospitals can be made. Then comes immunization. So, we are going to discuss about the immunization where the vaccines hold promise of saving millions of the children who are dying from the pneumonia. So, the vaccine is promising us to save the lives of millions of children who are dying from pneumonia. Three vaccines have potential reducing deaths from pneumonia. These vaccines work to reduce the incidence of bacterial pneumonia. First comes the measles vaccine. Pneumonia is a serious complication of measles. As I told you earlier, the pneumonia is a serious complication of measles and most common cause of the death which is associated with the measles worldwide. Thus, reducing the incidence of the measles in the young children through the vaccination will help us to reduce the deaths from the pneumonia. A safe and the effective vaccine against the measles is available to us from the past 40 years. So we see that we have the effective vaccine against measles. The vaccine type, it is an attenuated vaccine. Two doses of the vaccines are given. The first dose is given at the 9 months of age in the countries where measles is common, and 12 to 15 months in other countries. The second dose should be given later in the childhood, usually at 15 to 18 months. Is it clear? The countries where measles is common, okay, it is common, it is the other places it is uncommon. So the places where it is common, the first dose will be given at the age of 9 months. Where measles is common, it is given at the age of 12 to 15 months. Okay. The first dose is given at the age of 9 months, where it is common 12 to 15 months. The second dose is given at the age of 15 to 18 months. Later in the childhood, 15 to 18 months. The dosage is 0.5 ml. The route of administration of measles vaccine is subcutaneously. Moving further to the next vaccine, that is HIV vaccine, Haemophilus influenza type B vaccine. Haemophilus influenza type B, that is HIB, is an important cause of pneumonia and meningitis among the children in the developing countries. So, Haemophilus influenza type B is one of the important cause of pneumonia, and it is also an important cause of meningitis among the children, especially in the developing countries. HIV vaccine has been available for more than a decade now. It reduces the incidence of HIV meningitis. It also reduces the incidence of HIV pneumonia in the young infants and nasopharyngeal colonization by HIV bacteria. So we also see that because of the high cost of this vaccine, it has become an obstacle of its introduction in the developing countries. Since the HIV vaccine is very costly, to introduce this vaccine in the developing countries is an obstacle because of the low socioeconomic status of the population in the developing countries. The vaccine is often given as a combined preparation with the DPT vaccine or poliomyelitis vaccine. Then we see the type of the vaccine. It is conjugate. The route of administration, the vaccine is given intramuscularly. The dosage is 0.5 ml. And then comes the schedule of the vaccine. The vaccine is scheduled at 6, 10, and 14 weeks of age. So the vaccine is scheduled at 6 weeks, 10 weeks, and 14 weeks of age, or according to the national immunization schedule. In many industrialized countries, a booster dose can be given between 12 to 18 months, which is providing the additional benefit to limit the burden of the HIV disease, especially among the children. Is it clear? In the industrialized countries, we are also giving a booster dose between 12 to 18 months, which is giving additional benefit. The vaccine is not generally offered to children aged more than 24 months. So the schedule is very important. 6, 10, and 14 weeks. 6, 10, and 14 weeks. Booster dose from 12 to 18 months. Okay, this is week. 6, 10, 14 week. And booster dose 12 to 18 months. Route of administration intramuscularly, conjugate type, and it will prevent against the meningitis and pneumonia. Moving further to pneumococcal pneumonia vaccine. So we have pneumococcal pneumonia vaccine PPV23. It is recommended for all the adults aged 65 years or older, or anyone 2 years or older with certain medical conditions which is leading to an increased risk of pneumococcal disease. So the pneumococcal pneumonia vaccine is given to the elderly age group, that is 65 years or more. It is also given to children who are older than 2 years suffering with some medical condition who are having an increased risk to pneumococcal disease. The vaccine type is polysaccharide non-conjugate vaccine. The dosage is 0.5 ml. The route of administration, it can be given either intramuscularly or subcutaneously. Moving further to pneumococcal polysaccharide conjugate vaccine, that is PCV. The vaccine type is conjugate. In the name itself we see pneumococcal polysaccharide conjugate. So the type is conjugate. Route of administration is intramuscular. The dosage and the schedule. Dosage is 0.5 ml per dose. The vaccination schedule, the PCV is administered to the children from 6 weeks up to 12 months. The 3P plus schedule. So we see that for the PCV administration to infants, the World Health Organization recommends 3 primary doses. The 3 primary doses plus 0 schedule, or as an alternative, you can give the 2 primary doses plus 1 schedule. In 3P plus 0 schedule, the vaccination can be initiated as early as 6 weeks of age. You see, the 3 doses can be initiated at 6 weeks of age with an interval between the doses of 4 to 8 weeks. We see the 3 doses 4 weeks apart at age 6, 10, 14 weeks, or 2, 4, and 6 months depending upon the program's convenience. Is it clear? What are the schedule and the dosage? 3P plus 0 schedule. What is 3P? 3P is the 3 primary doses. The 3 primary doses are given 4 weeks apart at 6, 10, 14 weeks of age. 4 weeks apart, 3 doses are given. Is it clear? And then comes 2P plus 1 schedule. two doses, they are given 8 weeks apart. The 2P plus 1 schedule is selected where the two primary doses are given during infancy at as early as 6 weeks of age at an interval of 8 weeks or more for an infant, 4 to 8 weeks or more between the primary doses for the infants who is 7 months of age. You can see here 2P plus 1 schedule, 2 doses 8 weeks apart and a booster dose from 9 to 15 months. For the children who is aged from 12 months up to more than 2 years, 2 doses are given 8 weeks apart. For the child who is aged 2 to 5 years, just a single dose is given. Is it clear? A child who is aged up to 2 to 5 years, a single dose is given. Single dose is given from 2 to 5 years, and for the child 12 months up to 2 years, 2 doses are given. Up to 2 years, 2 doses are given at 8 weeks apart. Children 2 to 5 years, just one single dose is given. Is it clear? Lastly, we will discuss about the general advice. In the general advice, we see how to avoid the infection, and we have to stop spreading the respiratory viruses by washing our hands oftenly, lather soap and warm water for at least 20 minutes. We have to use a lather soap which produces lather, and warm water is used for at least 20 seconds. We need to wash our hands. Don't touch face. Keep your hands away from your mouth, nose and eyes. The respiratory etiquette, that is cover the mouth and the nose when sneezing or coughing. Dispose the used tissues properly in the trash bin and avoid the close contact a safe distance of 6 to 8 feet from the members. Wear a barrier, that is a cloth face mask or a face shield, will stop the droplets from spreading into the environment, and stay isolated, that is stay home when sick. Don't go out until at least 24 hours after all the symptoms have passed. We need to stay home when sick. Thanks for watching. With this, we come to an end of the session Acute Respiratory Infections, the part 2 of the video. I hope all the points are clear. If you have any doubts, put them down in the comment section. And if you like the video, hit the like button and subscribe.